Good
Good
evening,
evening,
everybody.
everyone. Yeah, so exciting. We are really excited for this evening, and we have a great group of attendees so far.
We do. We're excited for the whole month because we get to feature our Ovarian community in such a good, very impactful way and really giving a lot of good resources. So stay with us all month. We have 3 more events. Yeah.
I know we have a lot coming, so this is a wonderful way to kick off September. So we're really excited. So we'll give attendees another minute or so to hop on. We've got a
Yeah.
lot coming in so far. This is great. So maybe we'll just start off. I'll start by sharing my screen Sue, if you want to let some more people in.
You got it. Yep.
We do like to start off our digital education events with just sharing and thanking our sponsors because they are the supporters that allow us to continue to bring speakers and topics like what we have this evening and throughout the entire month, and real experts in their fields. So I do want to start off by just thanking our presenting sponsor, West, who has been a huge supporter from the beginning, as well as supporting sponsors Daiichi Sankyo, Merck, Lilly, GSK, and Immunogen. So we've got a big team just supporting our education initiative, and we are so thankful for them. And we have a great group and a great panel of experts this evening.
Yeah. Thank you, Erin. Just
Wonderful.
a little bit of housekeeping too. Yeah, just a reminder for all of our guests, you guys know Zoom all too well. You're all pros now, but we might as well go through it all, right? So just make sure you mute yourself just so all the background noise is not coming in. We'll have time to jump into questions, but you can always raise a hand. You can put in the chat. Erin and I will be monitoring the chat, so we will make sure that your questions get answered. You'll see Erin's doing a little bit of a sample right there, welcoming you to the speaker series. Know that this is going to be recorded. We always have our presenters front and center, and then we put it on our Her Library because so many people that cannot make it want to go back to the recording, as well as the decks and the presentations that we're using will be on the Her Library. So, if there's some reason that you had to go back and you wanted to see or hear a little bit more about what we talked about, you can find it there under uniteforher.org/Her Library. A little bit of a reminder for our Ask the Experts. So, next Thursday, September the 21st at 1 o'clock, we're going to have Dr. Mark Shaheen here. He is a Unite for Her board member, also our ovarian cancer advisor. He's also the chief of the Hajani Institute at the Gynecological Oncology at Abington Hospital. Together, him and Erin will be answering your questions about ovarian cancer on lifestyle, and then, of course, Erin's expertise on nutrition. So that is September the 21st. We're now going live on Zoom. That is correct, Erin. No more Be Live. We're on Zoom now for this one. So there will be a link in, we'll put it right in here as well. We'll be live on Facebook, and you just have to click on the link to sign up, or just go to our website under uniteforher.org/experts.
Yep.
We also give them an opportunity to ask questions too, Erin, right? So ahead of time, and
absolutely.
That way we take those questions and we monitor, and Erin will be your host, but she'll also be tag teaming as the expert in nutrition as well.
Yeah. So
and then Erin, do you want to do the second one?
Yeah, absolutely. Yeah. Like I said, this really just kicks off a month of ovarian cancer awareness. And so this is our first of 2 speaker series this evening. Our second is happening Thursday, September 28th, same time, 6 p.m. Eastern time, hosted on Zoom. We have a panel of 8 professionals representing some of the most influential and impactful ovarian cancer organizations in the country and the world. We will have representatives from Sandy Rollman, Clarity, Share, the Women's Foundation of the SGO, the National Ovarian Cancer Coalition, the World Ovarian Cancer Coalition, among others. And they will be sharing their resources for patients, for caregivers, as well as information on how you can get connected with them. This is a world of resources that we want to make sure that you are aware of and you have access to. So we are so excited to have these amazing partners join us for a big panel, lots of sharing, Of course, time for questions, and hopefully this will just help to build your supportive network. So we're really, really excited. So that's at the end of September the 28th, 6 p.m. Eastern time, and we'll pop that link in the chat as well for you to join us.
Yeah, I'll grab that link for you now, Erin. We have a great month ahead, and I am so excited about all of these resources for our ovarian community. We were blown away when we were at that roundtable, and just wanted to make sure we got them all front and center.
Yep, and Linda, that registration has come out. So at the link that Sue just popped in the chat, you'll see both of our speaker series. So you would see the event to register tonight as well as later this month. So that, you know, you can register up until the day of.
Yeah, and Erin, some of our panelists too, because we interviewed all of them, some of them have some really strong resources for caregivers as well. So we will be covering caregiving resources for the ovarian community as well.
Yeah, so
all
really
right, shall we dive in?
That. Let's do this. I'm excited.
All right, we'll bring in our guests front and center. We're going to start with Dr. Blank. So Dr. Blank is the Director of Gynecologic Oncology at Mount Sinai Health System and Professor in Department of Obstetrics, Gynecological, oh my gosh, gynecology. Why am I doing that? Darn,
I have the same problem.
What is wrong with me? What is wrong with me? And reproductive science at the Icahn School of Medicine. She is an associate director at the Tisch Cancer Institute, Women's Cancers, and the director of Women's Cancer Program at the Blavatnik Family Chelsea Medical Center at Mount Sinai. She specializes in treating patients with gynecologic cancers, including ovarian, fallopian tube, primary peritoneal, uterine, and cervical cancers, and in caring for those in increased risk of cancer. Dr. Blank has conducted extensive research on gynecologic cancers on topics including genetic predisposition, novel treatments approaches, fertility preservation, survivorship, and quality of life. By serving on the ovarian committee of the NRG, she is involved in the development of NCI-sponsored practice-changing clinical trials, and she has been a principal investigator for multiple clinical trials. She also collaborates with other researchers at the Tisch Cancer Institute on translational research in fields such as immunotherapy and DNA repair. All right, Dr. Blank, thank you for joining us.
Thank you.
Welcome. And how about Dr. Zamarin? We'll bring him in.
Yeah. To adding to our amazing panel this evening. So it's my pleasure to introduce Dr. Zamarin. So he is the Associate Professor of Oncology and Section Head of Gynecologic Medical Oncology at the Tisch Cancer Institute at Mount Sinai. He spent a decade as a faculty and translational research director in gynecologic medical oncology at Memorial Sloan Kettering Cancer Center before transitioning to his current role just this month. Dr. Zamarin is also a principal investigator and a translational chair on several institutional and cooperative group clinical trials exploring novel immunotherapy combinations in gynecologic cancers and other solid tumors. He also serves as the Translational Research Co-Chair on the NRG Oncology Cervical Cancer Committee. His clinical and laboratory research are focused on understanding of the mechanisms of immune recognition and resistance in gynecologic cancers and on the development of novel immunotherapeutic strategies, including vaccines, immunomodulatory antibodies, and genetically engineered oncolytic viruses. Amazing stuff. Thank you so much for both of you spending your evening with us. We're really excited.
All right, so Dr. Blank, we're going to actually start with you. And Erin, I know you're going to run her slides for her.
Yep, let me bring that up. And Dr. Blank, we'll have you go front.
Get you front and center.
Thank you.
You got it.
Thank you. So we're talking today together. We're talking about advances in ovarian cancer that are not all about BRCA. With all due respect to people that do have BRCA associated ovarian cancer, and I have many patients I love that do have BRCA associated ovarian cancer. Every time after I give a talk, people say, well, what about me? I don't have a BRCA associated ovarian cancer. So we're going to speak about that. And these advances do apply to you if you have BRCA mutation as well. So this is about advances in ovarian cancer in general. Again, I'm speaking, as is my new partner, I'm very excited about my new partner, Dr. Zamarin. Next slide, please. So I'm doing the first part here. I'm speaking about ADCs. So this is going to be the ABCs of ADCs. And ADCs are antibody drug conjugates. Next slide, please. These are my disclosures. My institution gets some research funding, but I do not have any personal disclosures. And some of what I'm going to be discussed is investigational. Next slide, please. So what we'll talk about antibody drug conjugates. We'll discuss the mechanism of data supporting and clinical use of, sorry about this name, mirvetuximab. I'm just going to call it MIRV, okay? That's what I'm going to call it throughout, and we'll explain folate receptor alpha testing. Next slide, please. So what are antibody drug conjugates? This is a class of drug, and this is a fairly, I'll just say it's a fairly new class of drugs. And the way they work is they have 3 parts. So this is a schematic of that. So the blue part there, the part that looks kind of like a Y, is a monoclonal antibody. And that means it's an antibody that just goes to one thing. And this is a protein that seeks a specific target on cancer cells. And then the green little squiggles, those are linkers. And that doesn't sound like it's so important, but it is. This attaches the drug to the antibody, but it's important because they stay attached in one kind of environment and they release in another. And then the orange hexagons is the cytotoxic payload. And this is the drug that actually does the work once it comes into the cells. Next slide, please. So this is the way they work. So basically, the antibody, that's that green Y, it attaches to the antigen, the protein on the cell, that's what it's targeting. And then it basically gets engulfed in the cell. And later on, I have another one that I like the picture a little bit better. And then once it comes into the cell, those linkers break and the bad stuff gets released and it starts working. And then basically that payload starts doing its work through the DNA and it disrupts other things, leading to cell death. Next slide, please. And the other thing that's interesting about these ADCs is once they get in a cell and start doing their work, there's a bystander effect. So they even start working on the cells nearby that don't even have that antigen. And it's almost like a pinball machine. So it just starts working at all of the cells nearby. So it really is the thing that's interesting about those, about what they call the payloads, is they're very potent. They only need a small amount to do a lot of damage. Here, damage is good. Okay, next slide, please. So the reason why there's a lot of talk now about ADCs, or maybe there isn't, but the reason why I'm speaking about these is because there was a lot of excitement. This is an exciting slide, you see. In last November, the FDA granted accelerated approval to mirvetuximab for folate receptor alpha. I'll explain what these things mean as we go. Folate receptor alpha positive, platinum-resistant ovarian, fallopian tube, or peritoneal cancer. Folate receptor alpha is what the antibody is going to go to. Platinum-resistant means that it's cancer that's come back less than 6 months from the last time a patient has had platinum, and I think you know what the rest of this is. So this is exciting. Next slide. So let's talk about what this drug is in terms of what I've explained that an antibody drug conjugate is. The other name for mirvetuximab is Elahere. You might have heard of that. So I'm going to say MIRV, but Elahere is the other name. I never say the whole name. They're all very long names. So when you talk about, we have the same picture here that we had at the very beginning. The antibody is to folate receptor alpha. And folate, I'll speak about that momentarily, but it's a protein that binds and transports folate into the cell. It's on a lot of ovarian cancer cells, but it's highly expressed in about 1/3 of them. The linker is a linker, not too much more than that. But the cytotoxic payload is called DM4. It's a tubulin inhibitor. Next slide, please. So folate is a B vitamin, B9 specifically. It has a role in metabolism, and it's lipophilic. That means it loves fat, and it requires active transport into the cell. It can't just float across it. It needs a specific receptor. And the folate receptor alpha is, well, it's very sort of self-explanatory, but it's a receptor on the cell that assists with folate transport into the cells. And it's actually limited on normal cells, but it's upregulated in cancer. Next slide, please. So when you talk about ADCs, or actually every time I've heard a talk, they always use a lot of war-related metaphors, and they love to use I'm doing it now myself, and I don't like war-related metaphors, but they also always use a Trojan horse, because you have something that looks relatively nice, like it looks like this nice little antibody, but inside is all this really powerful stuff. So they're really highly potent, and you only need a small amount to drive the effect. Next slide, please. This is the slide I was talking about that I think it sort of shows the picture a little bit better. So the way it works, again, is the antibody, that blue Y-shaped thing. It binds to the folate receptor alpha. It kind of gets engulfed. It's called endocytosis, where it kind of gets eaten in, if you will, by the cell. And that environment caused that linker to sort of release that payload. And then that payload starts going crazy. It breaks up the cells, and then it starts doing that pinball thing where it gets to the other cells nearby. Next slide. So I'll talk a little bit about, this is the study. So actually, interestingly, at first when they brought this drug out, they didn't know how to select for the right patients initially. So the very first study that was done didn't look all that positive, but then they learned how to select for the proper patients. In this study, it's called Soraya. I always like to share the names of the studies because they're very beautiful. So Soraya, they were selecting the right patients, so they selected patients that had highly expressed folate receptor alpha. And in this situation, what's interesting here is these were very highly pretreated patients, which means they'd had a lot of different lines of therapy. And when you've had a lot of lines, those lines didn't work previously. And a third of them had response, and half of them had control. And the other thing that's important in this picture is that a lot of people had this response last for a really long time. It was a durable response. And this is the study that led to the approval. Next slide. And this was followed up by a randomized trial, which means there were two groups, and it was compared, MERV was compared to chemotherapy. Next slide. And this was really exciting because this was presented at ASCO last June. And this actually was the first treatment to demonstrate a benefit in overall survival for patients with platinum-resistant ovarian cancer. And a lot of drugs that we have show that they shrink tumors, or maybe make the CA-125 go down, things like that. But it's not that common that we can find drugs that make people live longer when people have had a lot of prior treatment. So this is really deemed a new standard of care, and really is really exciting. Next slide, please. So that was a new standard of care for patients with certain patients with platinum-resistant ovarian cancer. And this is a new trial that is we've just launched, called Gloriosa. Again, a beautiful name. And that this may be another group of patients for whom this is good use. This would be for platinum-sensitive patients whose disease has come back less than 6 months after receiving platinum, and that this would be a maintenance regimen. So there may be other uses for this drug as well. Okay, next slide. Okay, and I'm going to move on to testing, but one thing I didn't mention about the drug is the side effects. Actually, I'll talk about it a little bit, but the side effects are actually, it's much more tolerable than a lot of other chemotherapies we have. So that's another thing that's important about the drug. So who is eligible for the drug? You need to first have your tissue tested to determine if you are eligible for the drug. So to do that, you don't need to, I mean, you need to have your tissue sent for testing. They need to get slides, and they need to do special immunohistochemistry, which means stain for specific proteins to see, obviously for folate receptor alpha, to see if your tissue will respond to this drug. So the important thing about this is it doesn't have to be it can be at any time. It can be when you're not getting treatment. It can be when you are getting treatment, but you want to think about the future. And it doesn't have to be the newest tissue. It's been looked at, and your original tissue is the same as, your tissue now. It could be 10 years later. So that doesn't change. So there are a number of different labs that do this testing, and some are free, and that actually changes. These three were free about 2 weeks ago when I last looked: NeoGenomics, Caris, and LabCorp, but your doctor will know which ones are free. So these can be sent, and I think it's worth doing if you haven't already done it. Next slide, please. So this is what it looks like. Again, I said that 35% of patients with ovarian cancer will have high expression. So on the right are those pictures, or what it looks like when they do the staining on the cells. The brown is how brown it is how much is expressed, and high is on the far right. Again, that study I mentioned where they didn't select the right patients, they were taking people that had medium and high. But if you need to have greater than 75% or expression to be positive. So when you get your testing result back, you're not getting a number, you're either hearing negative or positive. Next slide, please. This is what a negative report looks like. Negative, next slide. And this will be what a positive report looks like. So they tell you you can go get the drug. Okay, next slide. I'm not sponsored by anybody. I don't get any money. So the unusual side effect that you get with this drug is eye toxicity. So this actually scares a lot of patients. So I just want to speak about it a little bit. It's due to off-target effects, which just means that it's not because there's a lot of folate receptors in the eye. It's just like something that happens in the eye. You can't wear contact lenses if you're on this drug. So for me, that would be an issue. People worry that they're going to lose their sight. That is not what happens. You actually need to see an eye doctor before you start the drug, and then you need to see the eye doctor regularly. You get to space it out. You do get a lot of eye drops while you're on this drug, and you can certainly have dry eye, and if you start having more eye side effects, you might have to stop or hold or things like that. And you get a lot of attention paid to your eyes. So that's unusual and probably something you wouldn't usually think about. Next slide. Can you go one more further? I think these two are out of order. Sorry. Yeah. So when some other antibody drug conjugates, you can change up the antibody or you can change up the payload. Can you go back one slide? These two are the same antibody, but a different payload. So I'm not even going to try to say these two, but these are two that both target folate receptor alpha and use a different payload. The one on the right has been studied a little bit more extensively, but they both seem pretty, I can't tell you anything about them because they're both proprietary. So they don't really tell you what these payloads are. They just draw them a little bit differently, but they are being studied extensively. Next 2 slides forward, please. And then these are 2 other ADCs that have been looked at. These have different antibodies and different payloads. This one seemed to be very exciting, but has recently been a little less exciting due to some bleeding associated with it. But I'm sure there will be more things looked at right with that. This is the antibody there was called anti-NaPi2b. And then there's tisotumab, which is actually FDA approved for cervical cancer and was recently shown to have a survival benefit there. It had been studied a little bit in ovary. I don't know that it will actually ever come to fruition there, but I just think it's encouraging to see that there are antibody drug conjugates that have been successful in other GYN cancers. So, and that targets tissue factor, which is in many tissues. Next slide, please. So antibody drug conjugates, there are a number of them used in other cancers as well. An exciting one that has recently gotten some attention is one that has that targets HER2/neu. It's been really exciting. There were beautiful results in a whole bunch of different types of tumors with that. So I actually think that this is a really exciting area of drug development. And again, it's not that they don't have any side effects at all. The side effects tend to be a little bit different. They may generally be driven by the payload. Sorry about the war metaphor. So the payload in MERV is sort of a cousin. A lot of them are sort of cousins of Taxol. So they can have side effects related to Taxol, maybe not as bad, but that's just sort of where you would think about that. Next slide. I'm on the closing end of what I'm talking about. I'll give this over to Dmitriy momentarily, but I'm going to sound a little bit like a broken record here because this is a story of progress, and it's a story of the beauty and the effect of clinical trials. So clinical trials are what moves, science forward and is why people now are living longer with ovarian cancer. Next slide. So there are a lot of benefits to ovarian cancer. This is just one thing, and nobody should go on a clinical trial for this reason, but it's actually been shown that going on clinical trials is associated with improved survival in patients with recurrent ovarian cancer. Next slide. But there are other reasons to go on clinical trials. It really just gets you access to new drugs. You're working with the people that are leaders in your field. You're taking an active role in your healthcare, and it's really an opportunity to make a valuable contribution. And the way the standard of care now is really been driven by patients who go on clinical trials. I think that it's really amazing how far we've come, and really thank you to anyone on here who's been on a clinical trial. And next slide. Thank you. Appreciate the chance to speak to you.
Thank you, Dr. Blank.
That was wonderful. That was wonderful.
Yeah. I love that you finished with the clinical trial pitch, because it is so important. We've been talking about it so much, and just how you get more monitoring too when you're on a clinical trial from your doctors. And I know that there's some hesitation in some people. So the more that we can just make this very normalized, the more that we're going to be able to make some really good advances in science.
Thank you.
So does anybody have any questions for Dr. Blank right now, or we can actually move on to Dr. Zamarin and then do some, at the end as well. Pop them in the chat, raise your hand. All right, Erin, so I think we move on, and then we'll come back with both of them. Yeah.
That sounds great. All right, let's pop in Dr. Zamarin. So yeah, we'll have plenty of time at the end for questions, but for now, Dr. Zamarin, the floor is yours.
Good. Thank you so much. Thank you for the kind invitation. And I actually want to start by echoing the last few words from Dr. Blank, and this is the importance of clinical trials. And there's a lot of misconception about trials in general. For the patients, many patients feel like they do not need to seek out clinical trials until they have failed every possible line of therapy. And this is absolutely wrong. We have trials for patients who have the disease progression after standard therapies, but we also have trials for patients who may be newly diagnosed or have not had as many lines of therapy. And in a way, those trials may be even more important because especially when these drugs are used earlier in the disease setting, they actually increase the possibility of potential cure, meaning the disease not coming back. So if you're ever seeking out the next line of therapy, this should always be your question. Should I pursue a standard line of therapy or perhaps a clinical trial? Because many of the trials actually take a standard drug and add something investigational to it in a way to improve the response or at least the duration of potential benefit that you can have. All right, so I have been challenged with introducing you to cancer immunology and immunotherapy in just a few minutes. So I will try to take that challenge on. So please bear with me. And this is meant to provide you with an overview of what we have in what tumor immunology is, or cancer immunology or immunotherapy is, and what can we actually, what are the successes and failures that we have had in ovarian cancer. And I always like to put up a picture like this. This is a statue of Edward Jenner. So Edward Jenner is considered to be a father of immunotherapy, not cancer immunotherapy per se, but just any immunotherapy in general. He was the first one to recognize about 250 years ago that people who have had exposure to a virus that's similar to smallpox would never get smallpox later. And this, of course, led to development of a smallpox vaccine based on a related virus, and of course eradication of the smallpox. And many of the cancer immunotherapies work by very similar mechanisms. So our big pie in the sky is that we could eventually use immunotherapies to teach the immune system to recognize cancers just as well as the immune system can recognize infectious diseases. So what is cancer immunotherapy? Well, if we look at any cancer under the microscope, we can see that the tumors are not just composed of cancer cells. There are many other cells in the cancers. This is what we call a tumor microenvironment. So in addition to these ugly pink cancer cells, you have a bunch of other cells and these can be broadly categorized as bad immune cells and good immune cells. And an example of a good immune cell is a T cell. It's and the T cells are the ones that are the good actors, the ones that drive sort of a recognition of the cancer cells and killing. So the T cell is the cell that we want to focus on. And this is the one that's indicated here as the cytotoxic T lymphocyte. So how does the immune system recognize the tumor as non-self? Like the tumor is in a way a pathogen or like a virus, and somehow the immune system needs to learn that the tumor is not self in order to recognize and kill it. So this is the way that we understand how the immune system works when it comes to recognition of the cancers. So again, the principal cell that we all try to activate is the cell called the T cell. And the way that it happens is that the tumors, in the process of just normal growth, they lyse, so the cells die. They release what is known as antigens. These are different types of proteins that are seen as foreign by the immune system. And this is because these proteins are not normally expressed in normal cells, or they are proteins that are a result of different mutations that a cancer may have. So the T cells recognize these different mutated proteins. They see them as foreign. The T cells become activated. They multiply, so you get many of them, and then they migrate to where the tumors are and hopefully mediate the tumor cell killing. But if that mechanism worked every single time, none of the patients would ever develop cancer. So there are obviously mechanisms by which the cancers have learned to evade or suppress this immune response. And some of these mechanisms are what we call intrinsic to T cells. They're just different types of proteins that get what we call upregulated, or they come up on the surface of the T cells as the T cells become activated. And these proteins act in a way as a brake in a car does. They prevent the T cells from being fully active. Why is that important? Well, because in the setting of a normal infection, for example, we don't want the T cells to become too active, otherwise patients would die from an autoimmune disease or a lot of inflammation. But cancers have learned the mechanisms to exploit this natural ability of the T cell to shut down itself, and use these mechanisms to shut down the T cells and prevent them from working appropriately. So cancer immunotherapy or different types of immunotherapies may target different parts of this process. And so, for example, you may have heard about cancer vaccines. How do cancer vaccines work? Cancer vaccines are essentially these tumor proteins or antigens that we provide to the patient in very, very large amount. And the idea is that for these proteins to train the immune system to recognize the vaccines, so then that these T cells could migrate to the tumor and kill the same the cancer cells that express the same proteins. Another type of immunotherapy is that without just using the vaccines, we can use other types of what we call adjuvants, other small molecules that act to activate the immune system. There are mechanisms to try to remove some of these suppressive cells in the cancers. There are also ways to bypass this entire process. There's a type of therapy that's actually approved for some hematologic cancers like lymphoma called adoptive T cell therapy. And we essentially take the T cells out of the patient, we grow them to a very large quantities. These are T cells that are specific for the cancer, and then we infuse them back into the patient. So that sort of bypasses this entire process. We can also use molecules called cytokines. These are normally inflammatory molecules that are produced by the immune system, but they can be actually made into drugs. We can engineer viruses to specifically recognize and kill cancer cells and activate immune response. But perhaps some of the most widespread types of immunotherapies are the ones that we call immune checkpoint inhibitors or immune checkpoint blockade. And these are, again, the antibodies. So they are drugs that specifically target these inhibitory pathways on the T cells. And you may have heard about many of these drugs. The examples of them include pembrolizumab or Keytruda, nivolumab or Opdivo, dostarlimab or Jemperli, and so on and so forth. And these drugs have been effective against other cancer types and in fact are FDA approved against other cancer types, but not against ovarian cancer, unfortunately. And I'll show you why. So this is an example of a study where the drugs, these immune checkpoint inhibitors, have turned out to be very effective. And this is the study of a drug called pembrolizumab or Keytruda in patients with endometrial cancer. So not ovarian, but endometrial cancer. And there are different subtypes of endometrial cancer that this drug was evaluated in combination with chemotherapy. So carboplatin, paclitaxel chemotherapy. And if you look at these survival curves, essentially what these curves indicate is that what percentage of the patients stay on the drug for a very long time without actually having disease progression. So every time the curve goes down, that means another patient has had disease progression and had to come off the study. So in this specific subtype of endometrial cancer called mismatch repair deficient, but even in the more common types of endometrial cancers, addition of pembrolizumab to the standard chemotherapy was very effective. You can see that many of these patients had very, very durable control of their disease in both of these cohorts of patients. But unfortunately, this has not been effective in ovarian cancer. So here are examples of two trials that have been explored in patients with newly diagnosed ovarian cancer. One of them is called Imagine 50. The other one was Javelin Ovarian 100. I'm not sure how people come up with these very beautiful names for the clinical trials. I know Dr. Blank has highlighted some other beautiful names for trials as well. But you know, the name for the trial unfortunately did not help the drug. So addition of the immunotherapy drug to standard chemotherapy was not effective. You can see these patients did just as well, or unfortunately just as poorly as the patients who received chemotherapy alone. And that was seen in both of these clinical trials. In fact, in this trial, it seemed like the control arm, which is the chemotherapy alone arm, did a little bit better. What about in patients with who had recurrent ovarian cancer or platinum-resistant ovarian cancer? So the Japanese have conducted this study of nivolumab, which is another PD-1 inhibitor, in comparison to chemotherapy. They call the trial Ninja. Again, more beautiful names. But again, this did not help. So yeah, so when you compare the curves of the chemotherapy alone versus the nivolumab, there wasn't that much difference. In this case, maybe chemotherapy actually did a little bit better. So why is this that these immune checkpoint inhibitors don't work in ovarian cancer? And there are many potential explanations. It is some of the research that's actually being performed in our laboratories right now to try to understand that what is it that's so different about the ovarian cancer biology that makes it resistant to these drugs that otherwise work in other cancers. And then this is just sort of example of such a study demonstrating that ovarian cancers can be very what we call heterogeneous. And then that in the same patient, you can have some tumors that what we call are cold and don't have any evidence of being recognized by the immune system. And some tumors are very hot and they have a lot of these immune cells in the tumors. And as you can imagine, it's these hot tumors, the ones that are more likely to respond to the immunotherapy. And in fact, sometimes we see that even the patients that receive these immunotherapies have some tumors that shrink, and at the same time, some tumors that are that grow. And I think overcoming this type of what we call heterogeneity or exclusion of the immune system will be key to make immunotherapy effective in ovarian cancer. And how can we achieve that? Well, we can achieve that. We can best probably achieve that through rational combinations. Is basically, can we now take these immunotherapy drugs that we know can be effective in some patients, and then combine them with something else to try to extend the benefit to all of the patients. And we've done some of these clinical trials showing that, for example, if you take the drug like nivolumab, this is Opdivo, which doesn't have a good response by itself, but then if you combine it with another immunotherapy drug called ipilimumab or Yervoy, you can improve the response rate, meaning more patients have their tumor shrinkages. These graphs essentially, each curve is a different patient, and it represents how by what percentage the tumors shrink. And you can see some of these patients had tumors shrink by 100%, like there was a complete response. Unfortunately, many of these responses were not durable, and then even though some of the patients benefited, eventually the tumors started progressing again. But nevertheless, this is an indication that we can make more patients benefit from immunotherapy. And here's another recently reported clinical trial, also with a combination that's targeting the same targets, PD-1 and CTLA-4. This is with the different company drugs. But then once again, we see that the combination of these inhibitors can improve the response rate. You can see many patients have their tumor shrinkages. This is what we call a waterfall plot. So the bars going up, meaning patients have tumors growing, bars going down, patients have tumor shrinking, and each bar is a patient. And there's a good percentage of the patients that had their tumors shrink and shrink significantly. But you can see some patients had tumor shrink by 50% or more, with this patient having a complete response. So certainly watch this space, and we hope this was a very small study, but we're hopeful to see more out of this combination. There are also other drugs that can be combined with these PD-1 inhibitors. I have mentioned there's a class of drugs called cytokines. Those are small molecules that are normally produced by the immune system to activate T cells, but these can be expanded and then given to patients in larger quantities. So an example of those is this molecule called interleukin-2 or IL-2, and there's an engineered version of it to make it less toxic. And in this clinical trial with a drug called nemvaleukin alpha, which was given in combination with pembrolizumab, close to 30% of patients with ovarian cancer had a response rate, and about 70% of the patients had disease control, meaning the tumors were not growing. So now there is a confirmatory phase 3 clinical trial that's currently ongoing to see whether this kind of a therapy can really benefit a larger percentage of the patients. I want to switch gears a little bit and talk about these adaptive cell therapy approach. I have briefly mentioned it in the introduction. So what is adoptive cell therapy? It's essentially when we take the cells out of patients, modify them in some way, and then put them back into the patients to hopefully migrate or go to the sites of the tumor and kill the tumors. And the different ways to do this, one of the earliest types of these adoptive cell therapy was called tumor infiltrating lymphocyte therapy, or TIL therapy. And the way that it works is that the patient undergoes resection of their tumor. Then we have these T cells that we isolate from the tumors, grow them up in culture to very large quantities, and then infuse them back into patients. And this has been shown previously to be effective against melanoma, and more recently against cervical cancer. And there are some companies that are trying to develop this into a drug, although none have been approved in the US yet. The more common way to do this adoptive cell therapy is to actually just take the T cells out of a patient, so not from the tumor, but just from peripheral blood, and then to genetically modify these cells to specifically recognize something that's on the surface of a cancer cell. So this is very analogous to the antibody drug conjugate, or ADC therapy, that Dr. Blank has spoken about, but except that instead of delivering a cytotoxic drug to the cancer cell, you are delivering an entire cytotoxic T cell to the cancer cell, so that the T cell could mediate the killing. And this is another approach that has actually shown to be very effective against cancers like lymphoma and leukemia, and some types of leukemias, and actually already have FDA approvals. We're not just trying to determine whether these types of strategies could be effective against what we call solid tumors, and this could be cancers like ovarian cancers and others. And there is some evidence that these strategies can work against solid tumors. So here is an example of a study that was published recently. This was adoptive cell therapy that was targeting a molecule called mesothelin. It's a protein that's very commonly expressed by cancers like mesothelioma, but also by ovarian cancer. So in this clinical trial, the MPM stands for malignant pleural mesothelioma. So they have enrolled mesothelioma patients, but also some ovarian cancer patients. And you can see with the infusion of these cells, a number of patients, actually the majority of the patients, had some degree of disease control, and some have had like a pretty deep responses, including a few patients with ovarian cancer. I know that the cohort of ovarian cancer patients in the study is very small, but nevertheless, I think this study serves as a proof that this concept of adoptive cell therapy can work against these cancers. And here's another recently reported study, also with adoptive cell therapy, targeting another molecule called CLDN6 or Claudin-6. And again, this was done against a variety of solid tumors, but ovarian cancer patients who express these Claudin-6 molecules were included. And in this case, there was only 4 patients with ovarian cancer that were treated on this study, but 2 of them had pretty deep responses. So we're certainly looking forward to seeing more data out of this drug and drugs similar to it. Now these drugs do not come without it's not without cost. So some just because this is an immune activating drug doesn't mean that there are no side effects. And patients may experience side effects which normally result from inappropriate activation of T cells. So basically, there's too much inflammation that's happening, or instead of just activating T cells that target cancer cells, you're activating T cells that are also targeting some of the normal tissue, and you're having what we call autoimmune tissue destruction, very similar to autoimmune disease. So it is very important to recognize these side effects early and to treat them early. And of course, these side effects always need to be distinguished from other causes, such as infection or the actual cancer. So what can happen in response to some of these immune checkpoint inhibitors? In most of the patients, actually, we don't really see anything, and the patients feel great. But some patients may have some lab abnormalities, but you can have more severe or significant side effects, such as inflammation in the colon, inflammation of the liver or hepatitis, inflammation in the lungs, such as pneumonitis. Again, these side effects are not necessarily that common, but they may occur. And as I mentioned, early recognition of these side effects is very important. Because how do we treat this? Well, if you can imagine, if you're overactivating the immune system, we have to cool the immune system down. So these the treatments may include some topical steroids. You may also sometimes we give systemic steroids or other immunosuppressive medications to the patients. So I just want to conclude with the summary is that the cancer immunotherapies may come in many different types, and these may include immune checkpoint inhibitors, vaccines, adoptive cell therapies. The immune checkpoint inhibitors by themselves, unfortunately, have not demonstrated to be effective in ovarian cancer. But we think that the combinations of immune checkpoint inhibitors with other immunotherapies will be the way to go forward for treatment of this disease. And also, as I mentioned, that this new class of drugs called adoptive cell therapies can be potentially effective against some ovarian cancers, although we do need more data. These drugs are also very complex to produce and require specialized centers for administration. So I'm going to stop here, and again, I'll be happy to take any questions.
Thank you so much.
Thank
That
you so
was
much, Dr.
a
Zamarin.
wonderful presentation. Yeah.
For sure. We are on cue today, Erin. I feel like we both say the same things at the same time.
I know.
Yeah, Dr. Blank, thank you so much for being in the chat, answering all those questions. It really was an active chat, and we really appreciate that. I feel like we needed to give our audience a little bit of time to think about the questions, Erin. So
yeah, agreed.
At this point, we can continue to put them in the chat, or you can unmute yourself and ask as well. And I see Angela has her hand up. Is that right, Angela?
Yes. I thank you for this. I really appreciate it. Dr. Zamarin, can you go back and talk more about the heterogeneity of ovarian cancer?
Sure, absolutely. It's not a common, I guess, sort of a thing that people talk about, but at the same time, we know that it occurs very commonly. So by heterogeneity, what I was referring to in my talk is that within the same patient, we may have tumors that behave very differently. And I specifically was referring to very differently immunologically, meaning some tumors may be very well recognized by the immune system and other tumors are not. And there is no good assay to predict which patient has heterogeneous cancer or not, because we cannot go and biopsy multiple tumors from the same patient to say that this is the patient that has tumors that are all very similar, and this is the patient that's very different. So ideally, I think we need to design the drugs that would kind of work against all of these types of tumors, because hopefully we will have better biomarkers in the future, perhaps based on looking at patients' tumor images to say that, oh, this tumor is more likely to be immune responsive versus immune resistant. But unfortunately, we're not quite there yet.
Thanks.
Great, thank you. We have a couple questions here in the chat, right, Erin?
Yeah, I wanted to go back also to a question from Angela that she had asked, and Dr. Blank said Dr. Zamarin may know a little bit more to sort of expand in that response. So I didn't want to overlook that in case there was anything that you wanted to add to her response, Dr. Zamarin.
Okay, so the question was about whether for the mirvetuximab and other ADCs, are they using the same linkers? And then if a patient develops antibodies to ADCs, this is a very insightful question. Is basically the key question is basically if can you develop antibodies or an immune response to these antibodies, because they are kind of foreign drugs that are introduced into the patient. So this is this is something that the companies monitor all the time. because obviously this is a concern, that whether this is a potential mechanism of resistance to the drugs. The way that these antibodies are engineered is that they try to make them as, quote unquote, as human as possible, to minimize the development of the antibodies that would neutralize them. And the other thing is, like to be honest with you, we frequently overdose the patients. I think the doses of the drugs that are, and I don't want to use it in a bad way, but the doses of the drugs that are frequently used for some of these clinical trials are much higher than that's actually needed. And often, even with the dose reduction, we see that the patients may still respond. But hopefully, even in the patients that do develop these kind of what we call neutralizing antibodies, we're able to overcome it by giving a sufficient dose of the actual ADC. But are the companies using different linkers? Yes, and in fact, this is how the patents, I think, for these drugs work. Is that the companies say that by using their specific linker, they can add more chemotherapy to the same drug, for example, and have a different what we call ratio of the antibody to the drug that's linked to it. So and we don't know, quite honestly, what is the best linker. We don't like the linkers that fall off by themselves, because that means that the chemotherapy will fall off of the drug while it's being infused into the patient, and may cause side effects at the other sites. But you know, as we learn more and more about these drugs, I think the technology is also constantly evolving. It is a very exciting field.
Wonderful, thank you. Karen has her hand raised, so Karen, feel free to come off of mute.
Thank you. Dr. Zamarin and Dr. Blank too, those were really, really great presentations, really helpful. I have active disease, and I'm on Taxol right now, which seems to be working a bit, and I'm going to be on it for 2 more cycles. And then I think I might be investigating clinical trials, but it's a little, I'm going to really go by my oncologist's, you know, recommendation. But my question for you, Dr. Zamarin, is how far away are we? Can you guess or say? Some of those immunotherapy trials looked so interesting and promising. And I was just tested and found to be HER2 positive. So that's one that, you know, my oncologist now has on the back burner. But for the immunotherapy, which I know ovarian cancer traditionally is just doesn't work for, how far away do you think we are from these being FDA approved, or maybe being off label for ovarian patients?
That's a very important question, of course. So it's much of the data that I have presented is unfortunately still relatively early, and I think it will happen. I think these drugs will get approved, but I can estimate that it's going to be at least 2 or 3 years before larger trials are completed in order to result in the FDA approval. And the other thing is, for these adoptive cell therapy trials, you can imagine how complex they are. You need to have a patient come in, put in a special catheter to collect their white blood cells. These white blood cells need to be modified at a company and then shipped back to the hospital. This cannot be done in any outpatient setting. For these, the patients need to be admitted to the hospital, the cells get infused into them. So even after the drug is approved, the implementation of these drugs is not going to be that easy. So it's really going to be limited to these large kinds of centers. So as much as I like the idea of these kinds of adoptive cell therapies, and I hope that this is going to be a way to hopefully not just treat but to cure the ovarian cancer in the future, I think the implementation will take some time.
Thank you. I know, Diane, you had a question as well?
Yes, please, for Dr. Blank. I've been dealing with ovarian cancer for 2.5 years now. except for about a 6-month period fairly recently. It's just been constant. Taxol, carboplatin. I became very allergic to carboplatin, so that's off my plate now. Taxol didn't work. Avastin, so. I'm back on Taxol now, a weekly again, but it is working. The last numbers started to bring my CA 125 down a bit, but we did talk about Elahere the other day, my oncologist and myself. And I was reading quite a bit about it online, and honestly, I'm scared to death about my eyes. All the chemo I've had has really damaged my hearing, something terribly. And I'm just so concerned. I know you have to have steroid eye drops 6 times a day and moisturizing drops 4 times a day and going to see the doctor every 6 weeks. But I'm hearing stories from not too many people because it is so new, but about blurry vision at night. And I live alone and I have to be able to drive. I'm just so frightened that, how it will affect my eyes. So between that and also the neuropathy, I'm hearing fingers and toes neuropathy. I use the cold packs and the mittens and the ice bottles through all my chemotherapy, and I've been pretty good so far. But my eyes, can you talk a little bit more about what you have seen, reactions, the Elahere?
Yeah, I mean, I think that the people just generally are using those things. All but one of my patients, I have found that when they have eye issues, they've been reversible. Have you had the same thing, Dmitry? I think that it doesn't cause permanent damage. So I think that that's one thing that I reassure people with in general. You can also dose reduce a bit, and I think that things can improve. So I have had others, just as you say, who are, it is a scary thought that you would have a problem with your vision, but I think it is reassuring that you stop and it will come back. I think the eye drops, I think it sounds very daunting. I think you do it when you remember. I don't think you set an alarm for it. Don't tell your doctor I said that, but I mean, you do it as much as you know what I'm saying? So I think the neuropathy can be an issue. I mean, it does, as I mentioned, it does have side effects like Taxol. Again, dose reduction is, as Dmitry said, a lot of these things, sorry, Dr. Zamarin said that a lot of these things are higher dose than they need to be. So it is important that the doses be adjusted for you. And maybe you need to start at a slightly lower dose. Again, I'm not supposed to say that either. Sorry.
Thank you.
I would second that. I actually haven't seen much of the problem with the eyes. I mean, we've seen it early on when we started doing these clinical trials, but then once we started implementing these eye drops, it's very rare that the patients report anything. And at worst, it's been a little bit of irritation, which is where you hold the drug or you reduce the dose. So I think eyes have not been as much of a problem. I've actually had more problems with diarrhea in my patients, quite honestly, which I haven't seen while we did in the clinical trial, but the eyes has been the least of the problems for what we've seen. Yeah.
Thank you. That's reassuring. Thank you.
Yeah, thank you. Erin, I see Angela Ellis. She has a question up as well. Angela, do you want to unmute yourself?
Hi, can you hear me?
We can, yeah.
Okay. Sorry, I'm in the car doing this. I joined the meeting a little late. I'm not sure if this was touched on. Like I said, I got out of my rotation a little late. So I'm currently battling breast cancer. I have my last treatment tomorrow for chemo. And then I also have a unknown BRCA mutation that we found out that I had. So ovarian cancer and screening is something that, I'm not trying to worry about so much right now. I'm just trying to deal with what I have with the breast cancer, but it's something that I know that I kind of have to tackle in the future. And so I guess my question is, and it's for either of the doctors, is where do you see kind of ovarian cancer screening going? I know there's not really, it's not like as, I would say like black and white, I feel like, as it is even with breast cancer screening. But even then, I mean, the guidelines are changing, as we saw, because I know that the pelvic ultrasounds are only so good. And so I guess I'm just curious as to, if either of the doctors have seen anything in the literature or anything that might suggest new advances when it comes to screening. Thanks.
You know, I hate to start my response with unfortunately. Sorry about that, but we haven't really found something that has worked all that well. And I think part of the reason for that is that I don't think ovarian cancer kind of eases in. I think it happens really quickly. I mean, that's my clinical feeling about that. So I think we can look and look, but I honestly think it's a part of it is the feature of what we're looking for. It's not a easy road in where you can find something and you catch it early. So that's one of the issues with it. I mean, the what you mentioned is what we have in ultrasound and the tumor marker CA-125, and you can do that. And I think people do that wanting it to be normal so they feel better. But I get it. I totally get it. But I'm sorry to say that we still don't really have something that's going to work. And I do think possibly when you get those two things done, if they're normal that day, that probably means they're normal that day, but it doesn't mean they're normal in 6 weeks. So that's what makes it really tricky. And I don't think you should get them every day. You know, that's not going to work either. So I'm sorry to have that answer for you. Oh, that's such a downer. But
I mean, I guess the only thing I was going to add is the only thing we know that works for this is the risk reducing surgery. And you know, this is something that we tend to recommend to the patients, because just like Dr. Blank said, these cancers, I think they escape and metastasize very early before we're able to detect them. And then it's and I have had too many patients who said that I had a normal GYN exam 2 months ago and now I have stage 4 metastatic disease, and that's a completely common occurrence. We just don't have good screening methods for it yet. So we always encourage patients to talk to their physicians about the possibility of the risk reducing surgery as early as possible.
yeah, and now we're also talking about risk reducing salpingectomy with delayed oophorectomy. So that means removing the tubes early with plans to remove the ovaries later. So you can still potentially do, and I could go on about this forever, so I'm sorry, but anyway, we're talking about more patient-centered approach to risk-reducing surgery. So that it's not necessarily what you might think about it. It's definitely worth exploring options. Sorry, Angela, I'm happy to discuss this more with you offline, but.
Thank you both. There was actually another question from Tatiana, a very similar question. She had talked about, you know, what can be done for prevention of ovarian cancer for patients with BRCA1 mutation. She's a breast cancer finishing treatment, and I think you all answered that question there. But yeah, it's a tough one, you know. And is there, you know, just in thinking about that, because I know I was faced with it myself as a breast cancer survivor, is there any concern that you would have if you're under 50 or over 50 when you get your ovaries out for heart health or any other type of disease that could just be a little bit more amplified that you have to watch out for?
Yeah, I mean, there is, you wouldn't take your ovaries out if you didn't have to, but when you look at some of those risks, cancer's not sort of balanced. You have to look at everything all together. So I think you have more ability to manage your cardiac risk factors than you do your cancer risk factors. That's how I think about it. Of course, you know, when you have somebody that has a BRCA1 mutation and then a really strong cardiac history as well in the family, I generally work with a cardiologist to make that decision. I think that it's not a straightforward question, but you certainly do have those risks. But again, you have to weigh the risks and benefits. There are things like osteoporosis. You manage that. Heart health. Again, you make sure that you are good about your cholesterol. You do all the things that you can do to manage those risks.
Great, thank you.
Yeah, great question. And I know we've gone a little bit over. If you have just a little bit of time, I think there's a really important question that Jill brought in the chat just about clinical trials and some of the misconceptions around getting a placebo drug, which I know Sue and I hear quite a bit. So I think that this is just a good reminder about this point in particular.
Yes, it's actually a very important point because and it's very uncommon actually that the clinical trials have placebo. So and placebo is given when it's a placebo is the standard of care. So to give you an example, a trial where a patient has completed treatment and now the standard of care would be to just observe the patient, or the trial is trying to evaluate whether addition of a specific drug can prolong the time to recurrence or perhaps increase the cures. This would be the kind of an example where a placebo would be given. Basically, you would be either getting this experimental drug or a placebo. And in that sense, placebo is something that if you were not on the trial, this is what you would get regardless. Another example, it could be when you have one drug that you would get regardless, and we want to combine it with another new drug, but we're combining it either with the standard drug or a placebo. So in that case, again, we are evaluating whether a standard drug is better than with placebo is better than a combination of that standard drug with something else. There is no way you would ever receive a placebo when you need to get a treatment and the only thing you're getting is a placebo. It's unethical. It would never be allowed. That kind of a clinical trial would never be allowed to be conducted. And again, the other thing is you should always ask the physician whether this is a placebo-controlled trial or not. Placebo-controlled trials tend to be late-stage phase 3 clinical trials where we're really trying to compare the patients. Many of the trials that we do are what we call earlier phase trials where everybody gets the drug or everybody gets a combination of the drugs. But you will always know what kind of a phase of a trial that is, and before you move forward, your physician should always explain to you those types of details.
Yeah, thank you. We've done quite a few, Ask the Experts and Speaker series on clinical trials. So, please go to her library and take a look and listen in, because it's exactly right. Like, you will always get the standard of care, and I think people get confused when that placebo is, nothing. They're thinking it's nothing, right? But it's not. The standard of care may have been to be nothing, like you had said, or the standard of care may have been one therapy with nothing attached. So I appreciate you explaining that again. And, we're all on that mission for more clinical trials for sure.
Absolutely. Wonderful.
I see Darlene had a question there. Maybe last one. What is your familiarity with Mekinist? Am I saying that right? Mekinist?
Yep. So the Mekinist is a MEK inhibitor. It is approved for patients with a special type of ovarian cancer called low-grade serous ovarian cancer. It doesn't really work for the more common high-grade serous ovarian cancer. And this low-grade serous is more rare, but it has a specific what we call drivers that make it make these cancer cells grow. And the drugs like Mekinist are the ones that would be used for it. It's a more rare subset of ovarian cancers, and there are other kind of clinical trials that are ongoing in that setting to see whether drugs like Mekinist by themselves or in combination could be used. But again, it doesn't work against the more common what we call high-grade serous ovarian cancer.
Are you familiar with it all? Have you done any or heard any information about it?
We use that drug in patients with the low-grade serous ovarian cancer, yes.
Okay, so I just started on, and my understanding is that it's literally just been approved by the FDA about 6 months ago.
The drug Mekinist has actually been approved for a long time for other cancer types. It's just because it was initially developed for cancers like melanoma. So, but in terms of its approval, or at least the listing by what we call NCCN to be treated for ovarian cancer, that has been relatively recent.
Okay, so can I just ask one final question about it? I've been on it for about a month now, and which I tolerated the carboplatin, the Taxol beautifully years ago. as my cancer continues to progress, I have a stage 4 ovarian, which is the epithelial low grade. Those treatments were no longer working for me. My cancer, it's either stayed steady or grown. So as my doctor's trying me on this mechanism, I'm having severe reactions as far as every known side effect that you can have, I get. The Taxol, the carboplatin, it was like a dream for me. I had no reactions whatsoever. I could go to work right after chemo, no fatigue, nothing. This one is so hard on my body. My liver functions are like 3 times the level that they should be, which concerns me, which is one of the side effects. So any suggestions on what the next move would be?
I guess every patient is different, and it's your side effects are not uncommon. Your complaints
Okay.
are uncommon. Just because it's a targeted drug doesn't mean it's going to be easier than chemotherapy. So many patients I've had who had the PARP inhibitors and said they tolerated chemotherapy with carbotaxol better than they did PARP inhibitors. So we don't want to say that like necessarily these targeted therapies are easier. And MEK inhibitors are known to be tough, and you're not the only one that's going through it, and it's very challenging for the patients to take, and we have to do the dose reductions, we have to alter the schedules, but sometimes we have to give a few days on and a few days off in order for the patients to be able to take it. So see what kind of a schedule you can work out with your doctor, but just know that this is actually a common kind of occurrence for this drug.
And that's kind of where she's heading me. But are those effective as helping the cancer when you take?
They can be. Yes, absolutely. Yeah.
Okay. Thank you.
Sure. Yeah.
Yeah. Well, thank you so much, Erin. What a fantastic panel we had. We cannot just, both of you, outstanding. I hope you come back again. We really did have an active chat, and you were just so on, point with all of our questions, and we appreciate both of you greatly.
Yeah, thank you so much. We appreciate your time. And as always, we will be sharing the recording, and we will be sharing their slides. So you can always come back and dive a little bit more, rewatch the session. There was a lot of information shared. So know that we will have that up on our library tomorrow.
Yeah, just a little reminder, we want to thank our sponsors. We can't do what we do without them. So we are presented by West, with our additional support by Daiichi Sankyo, Lilly, Merck, GSK, and Immunogen. And it enables us to do 36 of these speaker series a year. And we really have incredible experts that we can bring to you front and center, so you can just have that, self-advocacy work that you are all so invested in. So we are here for you, and let us know if there's anything that you feel like would be a great topic that maybe we haven't addressed yet. Erin and I are always looking for those topics that are front of mind.
Absolutely. And hopefully you will join us for the rest of our events that we have this September for ovarian cancer awareness. We have our Ask the Experts next Thursday. I'll be with Dr. Mark Shaheen. And then we have our panel of ovarian cancer representatives and programs happening on the 28th, all of which is on our website to register. So we hope that you will join us for those as well. But this was a great night of information sharing, and we are just so thankful to have these amazing physicians in our network. So thank you so much for joining us this evening.